we're going to talk about a chest tube and what it is. Now, some of the reasons why a chest tube goes in place are where does a chest tube go? It goes in between the lung and the chest wall, right? In between those kind of layers of the pleura. So we go into the pleuritic space where the lung is supposed to kind of glide up and down. Normally there's a little tiny bit of fluid in there that kind of lubricates things, but very small amount. So anytime we had anything in that space that shouldn't be there. Often in our situation, we're thinking about traumas, that somebody might have a tension pneumothorax. They might have a hemothorax where they have blood kind of in that space. They might have a hemopneumothorax where you have blood and air in that space. And you can also have other things like in a non-traumatic setting that you could have pus, you could have backed up kind of lymphatic drainage of fluid that's kind of, if somebody has some sort of malignancy, sometimes we'll get pleural effusions and stuff like that. So anytime we have something in between the lung and the chest wall that's not supposed to be there, typically a chest tube is the answer. If it's blood coming out, it typically needs to be a big chest tube. So think bigger. This is a 32 French. They do put bigger in, but this is kind of would be a standard size in that setting. You can also get down to really small chest tubes, like 8s or 10s, that are used more so for just drawing air, taking air out. So you have a tall, lanky guy like myself. I blow a spontaneous pneumothorax, maybe becomes a tension, and they stick a little chest tube in there to drain it off. Has a little, often it's like stuck to, you can go online and see them, that have like a little drainage thing. Essentially it's meant for nothing to come out, but it just allows any air to come out and has a little mechanical one-way valve in the ones that I've seen. So different tubes for different things coming out, bigger for fluid. The biggest would be for blood because we can get blood clots in there, so we don't want to occlude that tube coming out. So it gets put in, we just talked about kind of in that triangle of safety, 4th or 5th intercostal space, kind of at the base of armpit hair is where this should be. And they just make an incision through the skin, blunt dissect down through, and then they shove that tube in. Typically that's kind of in that 6-8 centimeters. When I was taking my critical care course, they kind of wanted there, was around that 8 was kind of where that sweet spot in most adults, maybe to 10. It would be, you would have a standing process on that if you're inserting chest tubes, or the clinician, the surgeon would decide. But you could kind of picture if that tube's in my chest at that kind of 8-10 centimeters, that's kind of wrapping down, and they tend to kind of thread it down if they're thinking blood, because the blood, if they're sitting up, or any elevators, the blood will pool at the bottom if we have them up at all. So an air kind of is easier to kind of flow around. If we build up any pressure, then it'll come through. So in the third world, this is a garden hose, right? They'll sterilize a garden hose, throw her in the big vat of water, sterilize it, notch some holes out, go on YouTube and go look at some third world chest tube drainage systems. And the end of it, so if you picture this, this is in my chest wall and into my pleural space. If I leave that unhooked, this just acts like a sucking chest tube, right? I breathe in, my diaphragm drops down, there's now a hole in the side of the container, and a lot of that air is going to go into between the pleural space. So you'd see chest rise. The problem is it's not anywhere that you can get gas exchange, right? Only a part of the air would go into down through your trachea and down to some alveoli. Lots of the air from your breath, from that diaphragm dropping down, would go into the pleuritic space, and you don't breathe out of there. That's the problem with sucking chest wounds, is that when they're sucking in, diaphragm drops down, air goes into the pleuritic space rather than down into actual alveoli. Make sense? So we can't leave that like this, right? So what they do, third world, we got a long garden hose, a little bit length of it, so it would have a chest tube. It might be just a garden hose and then down, and we'd have a length of it. And what they do is they take a Coke bottle, we sterilize our Coke bottle, put a bit of sterile water in it, and we tape it to the side of the bed. We stick the end of the tube into the Coke bottle, and then let's think about what would happen as I breathe in. So as I breathe in, water's gonna come up that tube, right? But water has weight to it, right? So you'll pull that water up 5-10 centimeters of water that will pull up. So we're decreasing lung volume by that much, right, of the tube, kind of that tidling in the tube. But the majority of the air, that's a very small, right? Like that's like 40 mils of your, what do you mean, 500 to a liter breath, depending on the size of you. so it's a very small amount. So that actually seals that off with water. So they call that a water seal, right? So that water, because if we leave that above the patient, now obviously if we bring that above the patient, we can pour water, right? If we brought that above the patient, we can risk we get water in the lung, we can put water into the pleural space, right? Because it's just an open system. It's just like a Foley catheter. It's just an open tube. So what in third world, into the Coke bottle. Now let's think about the things that could come out and what it would look like in the Coke bottle, okay? So when it comes out, if it was air, when they inhale, right, to get the inhale, you'd probably not see air bubbles, you'd probably see the water coming up the tube a bit. As they exhale, diaphragm relaxes, chest wall is allowed to relax in, creates a little bit of positive pressure in the chest cavity, and you push your air out, right? So any air in the pleural space, if there was any air there, it would get pushed out, and then it would very easily bubble out through the water. Make sense? So we'd observe it bubbling out, and when they inhale, water would come up the tube. And then back down, right? If there was any bubbling, it would come out. So we could see more likely on expiration, but is where we would see that happen, just with the mechanics. So we could watch, and we could kind of try to quantify like how much of a bubble is there, right? How much of an air leak is coming. Because what we're watching is air go in through the mouth, out through the lung, into the pleural space, come down through your tube, and bubble into your Coke bottle, right? So that means we're seeing an active pneumothorax, right? Where there's definitely air coming that was in through the mouth and nose, now coming out the chest tube, okay? Because we have a hole between alveoli into pleural space. So let's think about blood. So blood, what do you mean in the bottom? We've got our garden hose in, right? It's just gonna follow wherever, gravity dependent, wherever it can flow out. If it's a big enough tube, then the clots won't get stopped. Then it'll come down the tube, and we'd see our Coke bottle fill up. So you can see on our Coke bottle, we might have a line of where it was, and then it'll fill up. Now, obviously our water's not gonna get a little bit diluted, it's gonna have a blood and whatever else, but we'd be able to measure the volume difference, right? Because you can see from where we were, have a Sharpie line, and then where it fills up, that's how much came out of their chest as we came through. So air and blood as they come through, that's what we could see. So we can see bubbling, we can see quantity of blood, and we have a water seal. Does that make sense? So that's how a chest pleurovac system works. So now that we kind of have that Coke system in our mind, it's just an open garden hose into a bottle of water, so that when they breathe in, the water goes up the tube, so we don't suck air into the pleural space. When they breathe out, the water's going to fall back down to the original water line, and then any blood or air is able to escape out the tube, given that the tube is patent and open through and not kinked off or disconnected. So now a pleurovac system should feel a little less foreign, because it's a Coke bottle divided into a few segments to make it a little tidier and a little bit more expensive. So we have a chest tube. The chest tube, when inserted by the physician, we'd see inserted. So when we we'll follow through the system. When we see pick up the patient, the first thing we'd start off is look at the chest tube, and we'd say, what depth is that chest tube at? We could see, okay, well, it's at 8 centimeters, and that's 8 centimeters from the last fenestration, right? Like that's much more than 8 centimeters. This is 8 centimeters to here, so we're more like 16, maybe even 20 centimeters. So realize it's 8 centimeters from the last fenestration is what it is telling us, from the last hole. Then we follow along the tube. This tube is shoved into a drainage hose by the surgeon when they put it together. So they'd shove it into the drainage hose itself, and then we tape that with some pink tape, like the 2-inch waterproof tape. You know what I mean? Pink color, the skin tone. It's supposed to remain somewhat sticky. Waterproof might be an overstatement, but somewhat sticky in wet environments is what we'll call it, rather than waterproof tape. Can you see why that would have to be completely taped? It'd be like kind of a hole in any other system, right? If we had that open, then suddenly that starts sucking air in and out through here, blood could leak out there. We want to have that tape shut. Next thing that we would run into is our connection that goes into our pleurovac. So it's just got a little gasket on there that we can shove in and collects in and makes a nice perfect seal. As we go, makes it easy for changing tubes. As we follow that tube, it comes into this container. Now let's think about blood. Blood's going to come in through. Now obviously this would be gravity dependent, would have to be lower than the patient's chest wall. Water or blood is not going to flow uphill. I have it up on the table only because it's easy for you to see, right? So drainage systems always need to be below the level of the diaphragm, right? Because we want anything to drain out, so it needs to be below. So fluid that would come out of the chest wall is going to just like fall right into this container, okay? It's going to fill up 10, 20, 30, 50, 200. Then when it fills up, it's just going to spill into the next container. We go 250, 300, up to 640, 650, 700, 1600, 1700, 2500. They get thrown out before they hit 2500. Can't be emptied, it's garbage. Typically change can be institution policy. Typically every 2 days they're changing the Pleurovac system. So it's meant to just collect stuff for 2 days, okay? So that container. Now any air that comes through, this is all one container, but obviously the blood's just gonna fall as it kind of comes in. Air will obviously just build up pressure through the whole system. It comes down. So this is called the collection chamber. Does that make sense? That's just the area that we're gonna measure. Instead of putting lines on our Coke bottle, we're gonna put lines here. So if in the first hour, we would write the date and the time and we put a line across and that's how much drainage we had. The next hour, we'd monitor. So we'd wanna know how often are we supposed to monitor the chest tube as far as the amount of drainage, and we'd wanna keep documenting as per the clinician's request, I guess the practitioner who put it in. Then that air is able to come across, and we come into this area called a water seal. So the water seal acts just like sticking the end of our Coke bottle into the water. We just have a little bit more space before we get to the water. It's all a closed system. So that air, if it was coming through, it was pushing through, is going to push down through. It's going to go through that water easily and bubble out over here, right? And you see something here called an air leak meter. If I was the patient, right, and I got an air leak coming from my chest, my pleural space in, then you'd be able to see typically on exhalation, if the patient's intrinsically ventilating. Obviously it would be different if they were mechanically ventilating them, it would be the exact opposite. But with them breathing themselves, on inhalation, we'd expect to see water move up the tube. On exhalation, we might see some bubbling over. So if we had any bubbling, so that would be considered a grade 1 air leak, right? Compared to a grade 7 air leak, that's 7 plus than what I was doing. Anywhere's in before. So it's a little bit more to quantify than trying to be like, in the Coke bottle, it's like 30 bubbles? Like, I don't know. Do you know what I mean? It's really hard to measure. So this gives us a little bit of a gradient that we can make it a little bit more objective to say how much air leak is there. And obviously we'd like the air leak to slowly diminish over the weeks that this chest tube would be in place if it's a massive thing. And lots of patients that have chest tubes in have no air leak at all, which means they have no active pneumothorax at that time. Does that make sense?
If you pull some negative pressure on that now, does any...
No, we're going to show you what's going to happen. So when the patient breathes in, what you're going to see is...
Oh, yeah.
Yeah. Every breath going to come up 5-10 centimeters. Typically this dye is blue. It's just that I've reused it and
So
I put some bright stuff in there.
Never be enough pressure to actually get that fluid back in.
No, because it just weighs too much.
Yeah.
Okay.
Yeah.
So for them to pull it up, I'm sure if I, not through the chest, because right now what's happening is this is just into the pleural space. Yeah. When they take a deep breath, even as they forcibly inhale, right, they have a trachea, right? So I guess if we plugged and tried to suck really hard, maybe they could pull up through. I don't know. I don't think a patient's going to try to do that themselves. Does that make sense? We could try to pull water through. But 5 to 10 centimeters is pretty typical on a normal respiration, and that's all that we're required. When we get here, we see that, so that's our fluid, and so we have what it says a water seal, and we can measure the amount of tidalling as you're watching. So then you can see the amount of tidalling. And then during exhalation, you might see a little bit of bubbling. The next segment, so does that make sense? So we have the exact same features of the Coke bottle. We can collect fluid in it. It is a collection chamber. We have a water seal. The end of the tube is in water. And then we have a place that, in this case, we can watch the bubbles come out a little bit more objectively. So we have a collection chamber, a water seal, an air leak meter, okay? If we, the air leak meter, when we first get the Pleurovac to put fluid into the air to prep it, we just take sterile saline and we can inject in either pore here that can be used for suction, is where we'd fill that up. If you accidentally put too much, there's a pore here that we could scrub off, stick a needle in, and pull fluid out. We want the fluid to the 0 line where it's straight across. That's where the water line's supposed to be. You can overfill or underfill. Even after, if the patient's breathing in and out and we have a big air leak, we can get evaporation, so we can get that water line dropping after, I don't know, a couple of days. Let's say getting into almost time to change it, they might need to put a little bit more sterile water in. Okay. So the next thing is our suction. Now, suction is very rarely used now. There would be some situations, this would be only something that we would use if prescribed by the physician who was sending the device. And we're just going to hook up my suction here. I just have a Laerdal suction unit here. We'll stick that on, and I'll try to knock this over. I already broke one corner by knocking this over this morning, and I'll see if I can knock my coffee over as well. So it says here, dry suction control, which begs the question, what is wet suction control? It's something we used to control the amount of suction. Not used anymore in the developed world. You'll have a Pleurovac system that'll have a dry suction unit. That's the only thing that I've used. If you run into a situation that's for some reason somebody's wet, somebody's gonna have to teach you on that. It's not hard. I just stopped teaching it because nobody uses them anymore. So dry suction, it says here, so with dry suction, measured in the amount, so we go 40, 30, 20, 15, 10. It just says centimeters of water pressure instead of, over here, we've got millimeters of mercury on that. So just, you could convert between those. If you Google the formula, you could convert between those, just a different measurement of pressure. It says here, suction is operative when float appears in window. That's interesting. So this is a regulator. When I apply enough suction that a little orange float sticks up in the window, I can know that the amount of suction that's turned to, if it's set to 20 right now, that I'm applying 20 centimeters of water pressure. It doesn't matter if you turn your suction above that amount, it's a regulator, it's just gonna spill off any extra suction. It'll only provide the amount of suction that that dial says. But in order for it to provide that amount of suction, you gotta provide enough mechanical suction inside the device to get the float up into the window, and then you know that the regulator's applying appropriately. So I'm just going to clamp this off because he doesn't have this would be, he would have a ridiculously large. We'll clamp that off so we don't have just endlessly sucking air in, because obviously it would just have a huge air leak because it's an open garden hose on the end, right? In somebody's chest, it wouldn't behave like that. So we turn suction on. So we're gonna get suction. So we see the float up here in the window. See that little orange float? So I can see, when does it disappear? So dropped out when I'm at, it doesn't matter. You just need to have enough suction for the float to be present. There. So when the float's present, I can say for sure that we're providing 20 centimeters of water pressure. If I turn the gauge, do you see how it dropped out? Just means that I'd have to have more negative pressure for more pressure in here, which kind of makes sense. So in order for suction to work, you hook up your suction to the port on the back that's above the dry suction area. And then you're just going to apply enough pressure to pull the float up into the window, and then you know you're providing the amount of suction that's provided there. Most times, you'll never provide suction. So very rarely used, very good for getting stuff out of the pleural space, but can you see how negative pressure would also encourage continuing bleeding, right? Wouldn't help clot formation and stopping of bleeding at the site of injury. So suction is not used nearly as often. So very, very rarely is used in my experience. So so let's walk through a couple of possible problems that we could have. First of all, we talked about the positioning of the drainage system. It always needs to be below the level chest. That would also include the tubing. If you arrive, can you see that if this was sitting on the floor and you had a little a bit of tubing that was below, that the fluid would gather in here? So typically they'll run that along the bed in such a way that we don't have kind of an area that's going to gather fluid, right? That it'll kind of run a shallow line all the way down to the patient and drain into the system. In the trucks, so it's got hooks that we can hook on the side. Even if it's sitting on the floor, I'd suggest that you should hook it on the stretcher so it doesn't tip over. And we'll talk about what can happen. Do you see what I got water up here because of, a second here, let's see if I can fix that. I'm not sure how. I over suctioned, which it must have an air leak somewhere. There we go. Pardon me as I'm troubleshooting my, see if I can put it over into the drainage section.
I think it's one of those games.
Hey! I know.
Yeah.
Let's see if I can just do this. There we are. Perfect. Okay, so when so there's a little float there that's meant so if you flip it over, it's supposed to block this fluid from going into here. It doesn't work perfect. Okay, so if you tip it over, we lose our water seal. This is a container. If you turn the bottle on the side, you can see that the hose could be sticking into air, right? So the same thing, we could expose the system so there's not a perfect water touching all sides of the container, of this container here. So then we could have an open sucking chest wound. So drainage needs to be below, and now we're typically changed in 48 hours. Can you see that we should have tidling every time the patient's breathing? So inhale and exhale. I guess during inhalation we see it suck up. During exhalation we should see it fall back down. Let's walk through some possible problems that I could see happening. The first thing, let's just say, what happens if we tip, probably a more likely situation, if we tip this container over. So it gets tipped on its front or on its back, okay, rather than standing straight up. What will happen is whatever's inside these containers is going to now not just be in one cylinder, it's going to be spread across a number of cylinders, so it's going to make it a little harder for you. You'll be able to, you'd have to reset your marks and then start adding math and doing math and minusing things, but you'd have to make some notes around that. So as far as the drainage, we'd still be able to measure the drainage. It's just not going to be in nice, easy cylinders for us to measure, but the drainage would still all be there. What happens if you flip it on its side? Some of the water in the water seal can either come out the suction port or can escape. Some of it can escape, a little bit can escape over, as you saw, over into the other drainage side. But we might lose the amount of water in our suction, the seal that we need. So if we lost that water seal, it's like taking that tube out of the water. So what happens? What's the patient going to experience? Air is going to come in through that tube in the pleural space when they breathe in, rather than going into their lungs. It's sitting outside their lungs. And when they exhale, most of it will come out, and they'll just do back and forth. So they're taking a lot less functional tidal volume for all the chest is going up and down. It's just not going into alveoli. So what we could do, so if somebody did that, kicked it over, when you're traveling with these, you want to take a Kelly clamp, some pink tape, and a bottle of sterile saline. We spill. We'll bring the 1 liter sterile bottles that you crack the tops off, thinking about irrigating a wound or a burn or something like that. So just a 1 liter sterile bottle, which is your Coke bottle, right? So anytime we're transporting, take Kelly clamps, the 1 or 2 inch waterproof tape, and a bottle of sterile saline. Okay, that we wouldn't open it. It's just available. If you go to ICU, typically they have those things. They'll have like a bottle of saline, pink tape, and thing. Usually here they'll have them kind of on the window as you're going into the room is where they're sitting if somebody has a chest tube. So the first thing we can do if we lost our water seal is stop this from being a sucking chest wound. So what we typically do for the second shot, a gloved hand over the hole, right? So in this situation, what we can do is we can clamp the tube off. I guess it has to be, the tube has to be intact wherever the problem is. But if the problem was the container, I can clamp the tube anywhere in the hose, okay? When I would want to clamp the tube, can you make sense that when During inhalation, they suck air into the pleural space. Exhalation, it's going to be able to come back out. So we clamp at the end of exhalation. Does that make sense? So we clamp your tube off. So now that is essentially not a chest tube anymore. It's not a functional patent tube anymore. We can then fill up our container. So you need to take a syringe, grab some sterile saline, and pull up. I dumped this over early this morning, and it was about half empty, and it took 60 mils for me to fill it back up to the line. So it's a fair amount of saline. So don't think 10 mil preloads, think large syringe IV bag. And all you do is pull up the saline, and then you can insert, you don't need the needle on, just insert into the port where the suction hose goes on and fill right up. If you happen to fill too much, you can take a needle and you can swab that off, and you can pull fluid out through that port there. Okay, so that's if you knock the, I think that's the most likely thing that's going to go wrong, is you're going to knock it over. Then as soon as we got that water seal back on, we can open this back up and see that we got titling through. The next thing that I could think of going wrong is somebody getting out of the truck or something, putting the structure in, somehow we jam it and we crack the container. So what can we do? What does that function like when it's a cracked container? It's just the same if it's like putting a hole in any closed system. It's just going to pathically, so it's like having an open pneumothorax again. So the response will be, on exhalation, clamp off your tube to stop them from having this sucking chest wound. That's a glove over the hole. And then all we're going to do is disconnect from our pleural vac that is now garbage. There'll be blood and stuff leaking on our floor. We'll take our bottle of sterile saline, crack the top off, pour half out, and stick the end of the tube into our Coke bottle. And now we'll have a water seal again. We can unclamp, and they have a water seal, right? So it's the exact same thing as the developing world. And that's why we're always going to have that bottle of a liter of sterile saline, is so that if we break or something goes wrong, we can very easily add a water seal to this device. Make sense? So the next thing that I could think of going wrong is that you arrive and the patient, let's say we have some sort of a leak in the system. Somebody pulled the tube by accident, caught their toe a little bit, and something's leaking. So what would be a good indication of a small leak is that we lose titling, or the amount of titling that we had before. And like any tube system, like an endotracheal tube, I just want you to go to the patient's chest, and I'll go, okay, what's the bandage look at the chest? What's the depth of insertion? Follow down to the connection. Inspect that connection, is it good? Go down to the next connection. Is this connection good? Does this all seem to be functioning appropriately? Follow through to your system, no cracks in the system on either side of the chamber. Follow down, water in the system. Then we should have a patent system, okay? So if we had any kind of disconnection, then we need to have that pink tape. And when we're taping that tube, we tape in strips. So rather than taking that tube, wrap and tape around the tube, like that, we just take a long strip of tape, set it on the piece, and then wrap it around. That will hold a lot better. So you might do that on both sides or do a couple times. But for actual strength, if it gets a little tug, the wrapping around doesn't have much, it'll kind of peel open, whereas the tape along the edge won't. So the next thing that I could think of that could be going on here is that we get some sort of blood clot coming out, and it's kind of obstructing the tube, right? So what we would do in that situation now is that we can't do any maneuver that's going to create any substantial negative pressure on the pleural space. We can think of, so what we could do is take that blood clot and we could smush that with our fingers, right? So as long as we weren't doing sequential of this business, this could create negative pressure in the pleural space, right? Do you see how I could? But you could do like this, right? This is not creating negative pressure as I'm moving down. Okay, so we can squish those clots, move them around, all that stuff to try to help facilitate getting them through. We just can't create any maneuver. For sure, what used to be done is what they called stripping the tube, is they take like curling ribbon, you put your scissors on and you pull down really aggressively down the side, so you hold your thumb and go down the tube, and we could create these massive negative pressures inside the pleural space and create injury. So it would get the clot out of the way, but it would cause injury to whatever was causing that problem. The next thing that I could think of happening is probably the most frustrating. and hopefully with good tube management, is somebody catches the foot and rips the chest tube partly out. So if the chest tube partly out, what are we going to do? Right? They're going to go out. So how's a chest tube held to the chest wall? It's sutured, right? They kind of put these sutures around. It's kind of almost like a Chinese finger trap. The more you pull, the tighter it gets on the tube. And they suture it into the patient's skin, okay? So if they pull that out, that's going to hurt the patient. But you can pull that out, right? I can't do a chin up on their chest tube. It's not secured that well. So if they pull it out, whatever comes out of the chest wall can't get pushed back, right? Because everything is coming in tape and everything else is no longer sterile. We can't shove that back in because it's not sterile. Somebody's going to have to take that out, re-surgical the site, like sterilize the site, sterile gloves, and then put a new chest tube in. So if the tube was out and there was fenestrations showing, we'd want to put the occlusive dressings on the top and then lots of pink tape, okay, that we could keep and make that a seal again. It's possible that that gets pulled out enough that it's actually inside the chest wall and may not function anymore. I wouldn't pull it any further. I would just leave it where it is, secure outside, cover the fenestrations, and if it's no longer functional, you could run into a situation that if they have active pneumothorax, they could become a tension. You might have to needle decompress them, okay? Hopefully you don't pull the chest tube out. What if you pull it all the way out? It's just a sucking chest wound. I say just, you're gonna have a bit of paperwork to do. But you pull the chest tube, it's a hole in the side of the chest. So how do we treat that? We want to, ideally, I would say, you should all have a commercially available chest wall device. Should have a couple of them. They're not that expensive, and everything else doesn't stick. We talk about these three-way occlusive dressings, which is a nice thing. And if you've ever experienced, anybody had an actual sucking chest tube? I've had two, I think, in my career that are actually air going in and out. They're a bloody mess, and it's hard to get anything to stick, okay? So what you need is a commercial device that would stick on there and be able to have it has that one-way valve that would let stuff out. If you're not, you're going to really struggle to get any seal whatsoever. So what's typically going to happen is whatever dressing you on there is going to require a hand to actually make it seal. And anytime that we're sealing, even with the chest wall thing, occasionally we'll have to maybe see, is air still coming out, right? If they start developing symptoms of tension pneumothorax, just because I shoot you with a gun, had a straight through hole, you move tissue planes and that stuff can seal up again, right? So you still might have to needle decompress, even though it depends on how big the hole is. I don't think this hole where we've had a garden goes is likely without a substantial to occlude again, but we'll have to be thoughtful of that. But it's like any other sucking chest wound as far as management. Any questions? Hopefully demystified a little bit. Yeah.
So if you have like a trauma patient, they're going by ground, we have that in, and they're getting to 2,500 mils. Can you empty that system?
Hopefully you cannot.
You cannot.
Doesn't empty.
So would you just ask?
You would have had to take it. Now, if you were leaving and they had now, hopefully you would be aware. So if they, in the first hour, if they've had 1,500 mils come out in the first hour, I would say, can we have an extra pleurovac system? So then all you'd have to do is, as it's getting full, is take your sterile saline that often comes in the kit, fill it up, and then disconnect here and replug into the new one. But you can't do anything, so it would be just a bit planning ahead.
Okay. Do you often so if you got there for the transfer, do you do the math, say like, what was the first volume in the hour, and then you do the math, like 4 hours
so typically in those big traumas, you might get a lot of blood out at first. And if you saw, hey, this is more than halfway full, I'd ask for a pleurovac to take it with you, so you have it if you need it. The likelihood of that actually happening is not great. But often these big patients, we're also transfusing lots of blood. Mm-hmm. Like how many liters of blood can they put out? Yeah. Well, I mean, and still be alive. Changes when we start dumping massive transfusion protocols and we're dumping 8 or 10 units of blood into somebody. Hopefully we're getting things to start clotting. But
it'd be nice
I would prepare and take a pleurovac. If it was a big trauma and you had it more than half full in an hour, I'd take another pleurovac with you. It would be also good to ask in the trauma bay what you should expect. they will have more knowledge about that patient and even experience with chest tubes to say how much drainage should I expect. And I always think take more than what you think you'll need.
Yeah. And
You'd hope they would elect to do that, like themselves.
You'd hope. It's kind of
They'd be
like
like, "Hey, we
taking
should give you an
propofol or
overuse."
ketamine on transfers. I go at the door and you're like, oh, well, this is I need twice the amount of propofol that you're sending with me, because they don't always see the 3 hours between us and the tertiary care center.
so just to disconnect that, you would just
to switch to another, you just
Yeah.
disconnect here and plug into the new. It'd be a new
Would
one of
you-
these. It would have
you
one of
would
these hoses
clamp-
on.
clamp, disconnect.
Exactly.
There you go.
Yeah, exactly. So you would clamp, disconnect, because now avoid that open pneumothorax. Reconnect, unclamp.
And do you like sterilize the opening?
This
stuff?
would just have to be sterile. We'd use like
Is
kind
there-
of typical sterile technique where we wouldn't be touching ends, right? I guess
Is there
clean
caps
technique.
on like new ones of these?
I think they come with the tubes already in place.
Okay.
This would already be in place. I'd have to go look, or there might be a cap over the top of each. I can't remember. I'm sorry. But like any like IV tubing, we would try to stay an inch, at least an inch margin back from the tips that we're considering where are supposed to be sterile. No need to clean when it comes out of the package, and just like we're disconnecting an IV to connect another thing, as long as this hasn't hit anything, no need to clean. We just disconnect from the old, connect into the new, because this is considered that is supposed to be sterile. Great questions. You want to hit stop? You